All right, welcome. We are going to talk today about some knee injuries, common knee injuries, and address kind of what the anatomy is behind the knee, what the anatomy is behind the injuries that are occurring, as well as looking at predisposing factors. Where are we sensing pain in these locations where the injuries are? And then ultimately be moving into what we could do to help treat them or rehabilitate them by looking at our corrective exercise continuums. So let's first start with the knee joint itself and looking at the type of a joint. Most people will say that it's a hinge joint. However, we do need to keep in mind that hinge joints only move in one plane of motion. And so if we think of like our elbow or a lot of our phalanges, they can only just flex and extend. But when we look at the knee, it does have another motion. When it's flexed, it can actually rotate. So you can have minor rotation of the tibia and fibula compared to the femur when we're in a flexed position for the knee. So technically that makes the type of a joint a biaxial joint instead of a hinge joint. But you'll see in most places, when you're looking at what type of a joint the or the knee is, they'll say that it is a hinge joint. When we look at our joint by joint stance and looking at whether we think that these areas of the body should be more mobile or stable, stability is what we are looking for in the knee. We really hope to build the stability around the knee so that it doesn't cause injuries. So let's take a little bit of a look at our anatomy review. As far as the bones that make up the joint, we have the femur, which is coming down in the thigh region. We also have the tibia, and on top of that, we have the patella and the fibula. Now, it's interesting that the fibula is not a weight-bearing bone. So we just need to keep that in mind. So although it kind of makes up the knee in general, because we do have some ligaments that attach onto it, it does not actually bear the weight of the leg or of the body at all. And then of course we do have the patella, as you can see, it's located here. That does make up the knee joint as well. And a lot of that comes because of we have the patellar tendon versus the patellar ligament. You can actually call the whole thing the patellar tendon as well. But remember, a tendon attaches muscle to bone and a ligament attaches bone to bone. So the patellar ligament and patellar tendon is something that's unique in that it actually is kind of attaching, it's one entire surface, but it's attaching muscle to bone to bone. So you can just use that as far as the terminology goes. Usually the upper, more superior section is called the patellar tendon, and then the lower section, the inferior section, is usually called the patellar ligament. So as far as the ligaments that are there to protect the joints, we do have a variety of them. We have the medial, or also known as the tibial collateral ligament. So that is going to be on our tibial side here on the medial side. And you can call it either the medial or the tibial collateral ligament. We also have the lateral or fibular collateral ligaments. Remember, collaterals are always on the sides of the joints. And then within here, we have the anterior cruciate ligament and the posterior cruciate ligament. So the ACL right here, and then right tucked in behind it, you can see the PCL that's there. As far as what's between the femur and the tibia, so these are our contacts, the articulating bones that we have there. And in between there, you will find the medial and lateral meniscus. And these mainly act as shock absorption for our body. So instead of just having that bone on bone, we do have that cushioned surface. It helps keep the integrity of the joint to a minimal extent, as far as like making sure that the tibia isn't slipping compared to the femur, but really it like spreads the weight out and adds that shock absorption feature between the femur and the tibia. So now let's do a little bit of review on the different motions that we have and the muscles that can contribute to it. So as far as knee flexion and extension go, I would love if you would take a moment to pause the video and to brainstorm. What is it? What muscles lead towards flexion of the knee and what leads towards extension of the knee? I'm going to continue on. Hopefully, you did pause the video and take a moment to try and recall off your own mind of what you know about flexion and extension, but we're going to take a look at them right now. So let's look at our flexion. The first thing that should be coming to your mind is the hamstrings. So the semimembranosus, semitendinosus, and the biceps femoris. So when you think flexion in the knee, that is one thing that I want to just have you come to the top of your mind that is a no-brainer for you guys. So work on that as far as hamstrings are doing flexion of the knee. We can also add in there the gastrocnemius, the sartorius, and the gracilis, as well as the plantaris and popliteus, although they contribute quite weakly. They're not strong contributors. So first think hamstrings, and then the next one that you should always go to is the gastrocnemius. And then we can move to the other smaller contributors like the sartorius, the gracilis, and the plantaris and popliteus. As far as extension goes, the first thing that should be coming to your head, because it's what we have for our knee flexion, is the quadriceps. So the rectus femoris, the vastus lateralis, vastus medialis, and the vastus intermedius. So our quads are what is dealing with our knee flexion. Same thing here. Let's take a look at that small amount of medial and lateral rotation that we can have. So take a moment to stop the video and brainstorm. What can you think as far as muscles are that lead to medial, or also known as internal rotation, and what leads to lateral or external rotation? So take a moment and try to brainstorm. When we look at our medial and internal rotation, we have the semitendinosus and the semimembranosus. So on that medial side of the hamstrings, we have those two muscles on that medial side, which will lead towards that medial and internal rotation. We also have the sartorius, the gracilis, and the popliteus that will all contribute as well. For our lateral or external rotation, it's just the biceps femoris. So that's that lateral hamstring that we have. So these are our contributors for medial and lateral rotation, also known as internal and external rotation. So now let's move on to some common injuries and impairments that we can have with the knee. We're going to start off with patellar tendinopathy and just talk a little bit about what it is. So as far as what it is an overuse injury, and it is inflammation or a partial tearing of the tendon. So of the patellar tendon, patellar ligament, we can start to have some micro tearing that is starting to occur in the area, and that can eventually lead to a lot of pain. So it does involve the patellar tendon and the patellar ligament. And the affected movements that it could be causing problems with would be flexion of the knee that might cause pain in it. As far as the location of the pain, it's typically just inferior to the knee on the tendon slash ligament of the patellar ligament. And it's often caused by things like jumping, running, walking, especially if we're going downstairs or downhill and we have a lot of eccentric contraction of our quadriceps can lead to a lot of that still, that minor tearing that's occurring and can actually inflame it and cause a lot of pain in that area. As far as predisposing factors that we have, so participation in a lot of those jumping sports like basketball and volleyball, where you're just putting a lot of stress on that patellar ligament and patellar tendon because of the contraction of the quadriceps. If you're overtraining on hard surfaces, that can often lead to injury as well. Or if you just have poor quad and hamstring flexibility, or if you are having overly strong quads balance by having weak hamstrings that can lead to the issues as well, because it's everything that's happening around where those quadriceps are attaching to the bone itself. If you are more of a flat-footed individual or having excessive foot pronation, you're more predisposed to having issues with patellar tendinopathy. And then also, if you have a misalignment of your bony structures, including a large Q angle. So when we take a look at a Q angle, if we were to draw a line straight down the tibia, so here you can see it coming straight down from the patella, from the femur to the tibia that we have located here, and also draw a line from the anterior superior iliac spine, so that's the very front of that iliac crest, and draw that line straight down all the way through the patella. This angle that you can see in between here is what's called the Q angle. So it's between this line that's created from the ASIS through the patella, and you can see this line better straight up and down from the patella, and it's really what is the center of that tibia coming up. So normal results are typically in males found to be around 14 degrees. Women, because they just have wider pelvises, tend to have a normal average of around 17 degrees of that Q angle. If it's accentuated and larger in the area, so going up to 20 or so, this is what we call a valgus position. So remember, that means that it's like the discontinuity is coming from the lateral side. And so you are seeing basically a knock-kneed individual in that case. So when we have a valgus positioning, that's also called knock-kneed, and that's when our Q angle is accentuated and is larger. If we have a Q angle that is smaller, we'll be taking a look at a Varus position where it's more open towards the center or towards the medial portion of the knee versus more open towards the lateral portion. We'll have that smaller Q angle, and this is the Varus position and what we commonly refer to it as bow-legged. So if we're having a larger Q angle, like we can see here in the center with the knock-kneed or that valgus position, that makes us more prone to the patellar tendinopathy, as well as some other knee issues that we'll be taking a look at. As far as recommendations, so what if you were to go to the doctor, what is it that you're going to be recommended as far as trying to treat the patellar tendinopathy? Well, if you refer back to our inflammation lessons, as far as using non-steroidal anti-inflammatory drugs or analgesics and ice, there is conflicting information on whether we should be using those. What it ends up doing is elongating the healing process or delaying the healing process when we are utilizing such things as analgesics and ice to be able to treat inflammation. However, if the inflammation is starting to cause problems itself, we might consider it. So it is something to think about. As far as rest, we do like to move things through injury. However, with patellar tendinopathy, we would avoid doing activities like running or deep squats or maybe lots of jumping, but still keeping up normal daily activities would be good for us to do. Sometimes they'll prescribe actually using an infrapatellar strap. So it's a strap that just goes underneath where the patella is, and that just helps to aid in the support of that patellar tendon or patellar ligament on that inferior section. If they are overly or excessively pronated and flat-footed, they'll often prescribe orthotics to try and fix that issue, to be able to open up a better space within the knee. And then we also have our corrective exercise continuum to work on our strength and mobility. So let's take a look at what that looks like. So remember, our corrective exercise continuums go through inhibition, lengthening, activation, and integration exercises. So the first thing we want to do is inhibit the neuromuscular messages that are being sent to the overly strong muscle groups, such as the quads and or the hamstrings. So foam rolling, other self-myofascial release we could do there. And then we spend time lengthening it and trying to make sure that we are going to maintain that. So first we break up the adhesions, we inhibit that neuromuscular motor messages that are being sent, and then we start to lengthen it through stretching. So we can do like quads and hamstring stretches as well as patellar mobility. And I'm going to show you that right here in this video. So in this video, you can actually see where we've got pushing down of the patella itself, and you can hold that for about 10 seconds or so, and then pull up on the patella as well. And so we're just trying to work on that patellar mobility a little bit. Now you can also go from side to side as shown here. However, I think you get the best results for patellar tendinopathy by actually just going superior and inferior. But here we demonstrated as well, just going from side to side. As far as activation exercises, we're going to do things like some isometrics of our quads, specifically focusing on the vastus medialis. And then there are some other exercises I'll show you in just a second on our straight leg raise. And some knee stabilization exercises as well. After we've activated the muscles that we are wanting to make sure that we're strengthening and kind of primed that motor unit to be able to fire and build up strength in those over time, we can start integrating with more complex movements, such as like doing a step up or doing a wall squat and having your back against the wall and the ball between your knees, and doing squats that way. Because you're trying to hold the ball, you are activating a lot of those vastus medialis muscles that you have on both sides. And then we could also work towards a hip hinge. As far as prognosis goes, it's usually completely healed through non-surgical means in about 2 to 3 months. So if you're experiencing these issues, usually takes about 2 to 3 months with doing some rehabilitation for it to get better. But let's take a look at some of these activation exercises that we have. So doing some isometric exercises, you can see here up in the upper left-hand section, that it's simply a contraction of the quadriceps. You can almost think of it as trying to push the back of the knee down against the floor. And what happens is we can specifically start to target that vastus medialis to try and build up that strength, because often that is the muscle that is the weakest when we're dealing with patellar issues. Our vastus lateralis tends to be pretty strong. We can now combine that with actually lifting up the leg. So here in the straight leg rest, you'll see first we contract the muscle of the quadriceps and of the vastus medialis. And after that contraction begins, we lift the leg up and then can put it down into the resting motion. You can hold it for about a count to 3 to 5. Make sure that people are breathing throughout this exercise, because this is a common one where people start to try and hold their breaths. Then we can also do some just knee stabilization exercises. Here we have demonstrated the resisted extension of the knee. So when we're trying to straighten our leg, we're doing this from a seated position right now, and we've got just a TheraBand wrapped around, and we are pushing forward to try and extend that knee and then bringing it back slowly as well. You could also do the reverse in a standing position and doing it with resisted flexion. But typically what gives the most bang for your buck as far as the exercising goes is the resisted extension that we have. So moving on to our next common injury or impairment of the knee would be the Patellofemoral Syndrome. So as far as what it is, this is when we get an abnormal tracking of the patella along the patellar surface. So the patella is not moving in the field that it is supposed to. It's not tracking with where it's supposed to be. The anatomy that's involved would be the patella itself, the patellar ligament and tendon, the quadricep muscles, and then also that patellar surface of the femur itself, which is the track that it is supposed to be running along. So affected movements would be that flexion and extension can cause pain whenever we're moving that patella with that leverage that we have when we do flexion and extension. As far as the location of the pain, it kind of depends on which direction the patella is starting to move in the wrong direction of the tracking of, but it's going to be in the area that's just directly surrounding the patella itself. As far as predisposing factors that we have, we're going back to that increase in the Q angle. So this is more highly seen in females, just because we tend to, as females, we tend to have a larger Q angle as well. Tends to hit in like our high school to early college age years. And ultimately, we have an imbalance of the quadricep muscles, and it's going to be in the direction opposite of the tract. So what ends up happening is that our strong, let's say that um, we're having strong vastus lateralis muscles, but weak medialis muscles, the patella will start to move towards that lateral side, and we're going to need to relax and inhibit these stronger muscles that are constantly activated and start to build up more strength and activation in the medial muscles. So as far as recommendations go, again, we need to take a look at whether we should be actually using anti-inflammatory drugs or painkillers and ice. Resting is advised as far as jumping and hard running, but normal daily activities of walking are encouraged. We can use braces or tape to actually move the patella, and that can relieve a lot of the pain while you're working through the exercises that we'll talk about. So this example that we're showing right here is when we had that lateral tracking where the patella was coming towards this lateral side because of the strong vastus lateralis. And what we're doing is we're holding the tape and pulling over to the other side, shifting the patella towards the more medial side to compensate for that. And that can actually relieve a lot of pain for individuals when they're experiencing the Patellofemoral Syndrome. So as far as our corrective exercise continuums, again, we're going to inhibit the muscles that are just overfiring. So often this comes on the vastus lateralis, but all of the quadriceps could be inhibited as far as foam rolling goes or self-myofascial release. Then we can do some exercises like the patellar mobility just to try and loosen everything up in the area and lengthen the connections that we have of the patellar tendon and ligament. And then also doing really good stretches of the quadriceps to try and lengthen those muscles. And then as far as activation goes, a lot of that will come with the isolated contractions of the weaker muscles. So the example that we gave in the last one was with our vastus medialis being the one that is more weak. So we can do just those isometric moves. And we can also do the straight leg raise is an excellent choice for us. Once we start to build more strength and activation to these weaker muscles, we can start to fully integrate by doing those wall squats with your back against the wall and putting the ball between your knees and just trying to keep that contraction in of holding the ball will activate the vastus medialis. And then working towards things like hip hinges and ultimately to single leg squats to help to try and build that integration and strength up in those muscles. As far as prognosis goes, we can have them return back to full activity whenever the pain is subsided. So just depending on how inflamed the area is and how much damage is being done, or how long it takes for us to rehabilitate those weaker muscles and get them functioning in a stronger capacity to put that patella back on the correct track for movement. This next one we're going to take a look at is Osgood-Schlatters Disease. And I think a lot of you probably have seen this in individuals or may experience it on your own. So here, what's happening is we've got our quadriceps and we have the patellar tendon to patellar ligament coming and attaching onto the tibial tuberosity down here where's that attachment is there. But when we're doing a lot of jumping exercises or just quick deceleration, it puts a lot of contraction on the quadriceps, which will pull this ligament, this tendon up, and ultimately it can start to actually avulse a portion of that tibial tuberosity. And when that happens, it can actually start to grow bone in between where the bone is coming off of the tibial tuberosity and where it was still attached. And it starts to become a larger, more pronounced bump that you basically have, a disforming that we have. You can see right here on this side, especially in comparison to this knee over here, we just have an accentuated enlargement of that tibial tuberosity. And that is just because of the strong quad dominance that we're seeing with jumping sports or rapid deceleration. So think things like basketball would be a prime example of it. You can also see it in soccer, volleyball with the jumping that is involved as well. So it's this repeated stress and or a rapid growth because of this tendon pulling away from the tibia. And so that can actually cause pain as it's occurring. And then we also sometimes get that bony growth that will start to occur. It's often found around the age of like 10 to 15 when we're having rapid growth spurts. So it's during those pubescent times. The pain usually will subside after the growth is done, but the bony prominence will still remain. So people will have this accentuated tibial tuberosity for life, but it will only cause them pain while they're going through this rapid growth period. As always, we can consider the ice and analgesics or anti-inflammatories. We do need to be cautious because it does impair some of the healing process. And so we just want to keep that in mind and only use it if the inflammation itself is causing too much issues. And then we would like to avoid any of those aggravating activities that is causing it, like the jumping or rapid deceleration, and work on a lot of the muscle lengthening as well. So a lot of this has more to do with trying to inhibit and lengthen than it does with activation and integration. So we'll see much more on the side of inhibiting those strong quadriceps and lengthening the quadriceps in order to compensate for the pain that is occurring.